thanks very much for doing that case. Look, overall I thought you did well. So your approach to the patient was very empathetic. You gained an easy rapport, your manners engaging, and you were responsive to the lady's or the patient's situation. When she described a mishap, you fed back that that could be quite traumatic. So it was good to hear that empathy. That I think encouraged the history and made the patient feel comfortable. The framework of the history was good initially. That you isolated the history of the presented complaint, and it was good to see that you were not only focusing on the fall and the fall into the pool and the aspiration, but you were cognizant that there may have been a precipitant to this fall, and so you're asking about possible neurological causes, cardiac causes as reasons of fall, and so that was good to hear. And indeed, she did have a history of falls. What I felt though is that that history around the falls and her reasons for falling wasn't quite unpackaged. Mm-hmm. And so it's still unclear to me as to what her normal functional status is, and how mobile and independent is she. Mm-hmm. Does she walk with a stick? How far can she walk? Mm-hmm. Is she still playing golf now? And the frequency of falls, I again didn't get a clear idea of, and I think one of the problems was that there was a little bit of a tendency to try to fill in the gaps for her. So right. I think you had a tendency to describe what you thought the history was, and then wait for her to say yes or no.
Yeah,
and
kind of feeding her that. Yeah.
That's right,
sure.
and I think she played along with that a little bit. And so, in someone who is a little bit verbose and tangential, it can be difficult. You can feel rushed in the history. And sometimes you do need to ask very specific questions to get those answers. And I think you did that well, but you just need to guard against the tendency towards leading the patient.
It's really tempting, yeah, sure.
And then in terms of going through the order of the history, is a little bit jumbled in terms of the sequence of medications, past medical history, and family history, and so it did jump around a little bit, I felt, and I think that potentially made you lose a few specifics on the past medical history which may have been relevant. One pertinent question I always ask as a screening for past medical history is, have you ever been into hospital for anything else? So you're asking about operations, but she has had other hospitalisations related to her falls, which would have been relevant to come out in the history. And then I think, as we were talking about on your discussion afterwards, trying to narrow down a little bit more, what were the respects behind her falling. I think anyone elderly lady that presents with a fall, even mechanical, there's respect is behind that mechanical fall, which you need to elaborate upon. In terms of your examination technique, again, the patient felt very comfortable with you, so that was good to see. It was a little disjointed again, I thought, in terms of method. You sort of went from the front to the back and then back to the front again, and it just looked a little bit awkward. Often it's better just to complete the respiratory examination on the front and then go down to the back. Don't forget to inspect for anterior expansion as well. I find inspection of looking at whether someone can fully expand their lungs and for the symmetry is often actually more sensitive than laying your hands on it. And so take some time to do that. And I did get a feeling that the examination was just a little bit rushed, and I think that's probably because it's related to the exam
Yeah,
conditions.
nerves.
And you did, finish at 7 minutes, and so
Okay.
you had time to complete the rest of the examination, gone for the cardiac examination, and etc. And so then, related to history, it would be nice to see you go on and do more of a complete cardiac examination, for example,
True.
because you're concerned that that may be one of the driving forces behind a fall.
Yes.
So the take-home point there is don't stop at one system. If there's other systems that you think are involved in the history that are presenting complaint or relevant, go on to examine those.
Okay.
In terms of the summary statement, I think you had relevant problem list. You're obviously worried about the reason that she fell over. You did kind of miss her primary problem, which we should have brought to hospital, and that was her aspiration pneumonia. So even though clinically that's resolving and improving, that still is
Just have to name it.
an active problem
Yeah,
that she's
okay.
getting treatment for, and so that should be added to the problem list, because she's going to remain on antibiotics for a little while, and you'll need to see resolution of her symptoms before she goes. It's good to hear about the cause of the fall, wondering about functional status, and her other past relevant past medical history. You had enough inquiry to think, well, it sounds like she's got a cardiac issue because of the medication she's on. She didn't give me much of a history, so I'd like to explore that further. So that was quite relevant. Within that, though, before jumping straight into the problem list, it would have been nice to hear more of a summary statement. So,
Sure.
Carolyn's a 84-year-old independent lady, but does have a history of falls. Who was brought in by an ambulance after it sounds like a mechanical fall into a pool with aspiration pneumonia of moderate severity. Her current active issues are, and then going through the problem list.
Yes.
So a summary statement. And the idea behind that is if you're talking to a colleague and you're handing over for their care, you can give a quick synopsis for them to hopefully gain a good clinical picture of that patient. So overall, I thought you did very well. And it's just, I think, that unpacking some of the more nuances and exploring that, which can be difficult in a time-pressure situation. Do you have any questions about the assessment or the feedback?
No, nothing off the top of my head, but thank you.
Very good. Thanks very much.